Good morning, dear students. Today we start lecture Influence of Lifestyle on Total Cholesterol, Lipoproteins, Triglycerides. Plan of lecture, we intend to discuss lipoproteins, different classes of lipoproteins, the role of lipids, dyslipidemia, classification of dyslipidemia, and we intend to discuss score system, assessment of general cardiovascular risk and factors aggravating serum lipids and measures to improve levels of parameters of the lipid spectrum. Physiological role of lipids. Lipids, they play not only negative, also a positive role. Total cholesterol, triglycerides, phospholipids, they are vital, necessary for human body. Total cholesterol acts as a part of cellular membranes, and moreover, total cholesterol is a precursor to the synthesis of many important substances such as steroid hormones, bile acids, and vitamin D. Triglycerides, they are the main components of adipose tissue, and we know that human body accumulate energy in the adipocytes as the triglycerides. And phospholipids, they are the basic components of the cell membranes. They regulate the transmembrane transport of various substances. This slide is demonstrating the simple steps of metabolism of lipids, and as soon as the fats, alimentary fats, they have been cleaved by the enzymes, the lipids, they are absorbed into the small intestine and transported through the lymphatic system into the bloodstream. But lipids, they cannot survive without additional supporting protein molecule, because lipids, they are hydrophobic molecules. That's why lipids bind to the special hydrophilic molecule. This is apolipoproteins. And these lipoproteins control fat metabolism and have different proportions of bound fat as well as different functions. That's why in as a form of lipoprotein, the lipids, they can be transported in the bloodstream to different organs. First of all, to the liver. Lipoproteins, this is structure of lipoprotein. Lipoprotein includes the protein, molecule of the protein, and triglycerides and phospholipids. Lipoproteins, they have different functions. The main functions of lipoproteins are transport of lipids. Second function, this is activation of enzymes involved in lipid metabolism, and third function, binding with specific receptors on the surface of hepatocytes. There are different classes of lipoproteins. We classify lipoproteins to atherogenic groups, chylomicrons, very low density lipoproteins, and anti-atherogenic group. This is HDL cholesterol. And here you can see the main structure of chylomicrons and very low density lipoproteins. They differ from each other by the size. First, chylomicrons, they have larger size than very low density lipoprotein, and but they transport same products. They transport triglyceride, mainly triglycerides, and also cholesterol esters. Look at these blue dots. But unlike very low lipoproteins, chylomicrons, they transport external lipids obtained from alimentary food. As for very low density lipoproteins, they transport internal lipids. Low density lipoproteins, very low density lipoproteins, they play important role in the onset of and progression of atherosclerosis. Unlike them, high density lipoproteins, they play anti-atherogenic role. They are responsible for transport of cholesterol from the vessels, human vessels, to the liver. What does it mean, dyslipidemia? Dyslipidemia, these are a group of disorders. These are disorders of lipoprotein metabolism, including lipoprotein overproduction or lipoprotein deficiency. And these disorders, dyslipidemias, they can be manifested by or elevation of serum total cholesterol, LDL cholesterol, and triglyceride concentration, and or decreasing in the high density lipoprotein cholesterol concentrations. And we know different types of dyslipidemia. We stratify dyslipidemia to primary and secondary. Primary dyslipidemia is usually familial dyslipidemia, hypercholesterolemia, and also we stratify to dyslipidemia to secondary causes. Secondary causes, secondary dyslipidemia, they can be related with cardiovascular and non-cardiac diseases such as nephrotic syndrome, Cushing's syndrome, diabetes, chronic kidney disease, maybe due to alcohol abuse, due to pregnancy, etc. This slide is demonstrating the Fredrickson classification of dyslipidemia, and according to this classification, all types of dyslipidemia, they have been stratified to 5 classes, and each class of dyslipidemia is characterized by appropriate changings of lipid spectrum. For instance, class 1 of dyslipidemia is usually manifested by increased concentration of chylomicrons, etc. All these 5 classes of dyslipidemia, they do not have equal distribution. The most common type of dyslipidemia, this is type 2, type 2B, maybe combined hypercholesterolemia, maybe familial combined hypercholesterolemia. These patients, they have usually increased serum LDL cholesterol and serum very low density lipoprotein cholesterol. But current time, it's practical clinical practice, this Fredrickson classification is not frequently used. This classification is very necessary for special lipid clinics. Why we have a strong concern about dyslipidemia? By the way, dyslipidemia, patients with dyslipidemia, they do not usually have specific complaints. Why we have a strong concern about dyslipidemia? This is related with a close relationship of dyslipidemia with the onset, incidence, and prevalence of cardiovascular diseases. And we know that cardiovascular diseases, they remain the leading cause of death among the world population at current time. Moreover, at current time, the scientific investigations, they have revealed increasing, growing of prevalence of cardiovascular related deaths. This is progressive with age, and the main reasons for the development of cardiovascular disease is atherosclerosis. That's why we should pay much more attention for dyslipidemia as a risk factor of the atherosclerosis. The dyslipidemia, this is main factor of all groups of patients with atherosclerotic cardiovascular disease. And the same situation is also typical for majority of countries, especially in Kyrgyzstan. And here you can see the publication, statistical data published in European Heart Journal 6 years ago, mortality from coronary heart disease, and comparing with other countries. Unfortunately, the mortality from coronary heart disease in Kyrgyzstan is remaining high. How to assess cardiovascular risk? That's why we taking in account high prevalence of mortality from cardiovascular disorders worldwide. It is highly important to prevent cardiovascular diseases and assess cardiovascular risk. In order to assess cardiovascular risk, we use recommendations from clinical guidelines from European Society of Cardiology, and risk stratification proceeds in 3 stages. Stage 1, clinical evaluation. It is recommended to highlight patients with high and very high risk of development of the cardiovascular disease. These are patients with high risk of cardiovascular disease, patients with diabetes, with renal diseases, and familial hypercholesterolemia, or patients with high score risk. And for high score risk, patients who obtained high score risk, 10 years risk estimated risk, they deserve much attention from healthcare. And for assessment of total cardiovascular risk, we put automatically high risk of high or very high cardiovascular risk if your patient has documented cardiovascular disease such as acute coronary syndrome, or if your patient have undergone stenting or coronary artery bypass grafting or other revascularization, or if your patient has had transient ischemic attack, or proven significant atherosclerotic lesion. For instance, you found coronary atherosclerotic plaques in coronary arteries, or in carotid arteries, or in peripheral arteries. So next group of patients with diabetes, they automatically considered as high or very high cardiovascular risk patients. Next, patients with very high individual levels of risk factors. For instance, patients with total cholesterol, serum total cholesterol more than 8 millimole per liter, or patients with hypertension, with chronic kidney disease, or patients with a calculated score 10% or more for 10-year risk of fatal cardiovascular disease. As for people older than 40 years, the definition of absolute cardiovascular risk using the score system is recommended. What does it mean, score system? This slide is demonstrating score system. We use simple questions. First, sex of patients, male, female. Second question, smoking status, non-smokers or smokers. So, next question is age of patient. And the next question, this is total cholesterol, serum total cholesterol in millimole per deciliter, in millimole per liter. And using this simple questionnaire, we can stratify patients to the risk. And this questionnaire is not difficult. For instance, let me use one example. If your patient is a male patient from 50 up to 54, for instance, 52 years old, and he is non-smoker, his blood pressure is about normal, 120 for instance, and his total cholesterol from 4 up to 5 millimole per liter, it means that your patient's risk of cardiovascular complications, cardiovascular risk is about 1%. We use this table. On the other hand, same age male patient, but smoker is a smoker with total cholesterol, high total cholesterol, more than increased total cholesterol, and arterial hypertension, his cardiovascular risk increased up to more than 5%. That's why we use this score system for assessment of cardiovascular risk. Where to find this score system? This score system is free for everyone. Is available in website, above mentioned website. We have to fill in this data about patient's sex, age, systolic blood pressure, total cholesterol, and smoking status. And according above mentioned score system assessment, as a result of assessment, we stratify all patients to 4 categories with low risk, moderate risk, high risk, and very high risk. And appropriate percentage results are provided here. Patients with score less than 1%, more than one from 1 up to 4%, from 5 up to 9%, and more than 9%. We use this classification for stratification of patients to 4 categories. Okay, how about how to manage patients with different cardiovascular risk according score system? Because the patients, they need to practical advice. And that's why we should be able to use this score system in our clinical practice. We apply to results of the published updated clinical guidelines of European Society of Cardiology and European Atherosclerosis Society, which was published in 2019 for management of dyslipidemias. We use 2 parameters. First, we use results of the score system, low risk, moderate risk, high or very high risk. And second parameter, we use results of the lipid spectrum, LDL cholesterol. And the next, we use these clinical guidelines for subsequent practical recommendations. I would like to show you two clinical cases. Two patients with the same age, but with different parameters of lipid, with the same parameters of lipid spectrum, but with different smoking status. First, both patients, they are at the same age, and let's pay attention that LDL cholesterol, they have matched about the same LDL cholesterol, but they have obtained different score system results. And according to the score, the patient number 1, his score is 4%. He belongs to the patients with moderate risk. The second patient, he obtained 10%. He belongs to very high risk. So they have same level of LDL cholesterol. Patient number 1, we recommend him lifestyle advice. For instance, increased physical everyday daily activity, physical activity, food diet recommendations. As for patient number 2, we recommend him lifestyle interventions and concomitant drug interventions. That's why using the same, so according with these clinical guidelines, we recommend patients different advices, different practical recommendations. But according updated new information, there are other factors modifying score risks. Family history of premature cardiovascular disease. If your patient's first-line relatives have had premature cardiovascular diseases, male relatives younger than 55 and female younger than 60 years. Second factor, elevated biomarkers, including ApoB, LPA, C-reactive protein, triglyceride, or atherosclerosis on non-invasive imaging. And next, social deprivation. Actually, this risk factor has been confirmed the origin of many of causes of cardiovascular disease, obesity, especially central obesity, physical inactivity, left ventricular hypertrophy, and chronic kidney disease, obstructive sleep apnea syndrome, and non-alcohol fatty liver disease. Factors modifying risk scores, they have additional factors affecting cardiovascular risk. And according recommendations for treatment goals, we try to achieve LDL, the target level of LDL cholesterol less than 1.4 millimole per liter in patients with a very high risk of cardiovascular complications. Or if it is impossible, if it would be impossible, it is recommended to decrease LDL cholesterol at least 50% from baseline initial level. And treatment goals for a low-density lipoprotein cholesterol. Treatment goals, they depend on the patient's initial status, risk according score. Patients with low score system, they have other higher treatment targets than patients with moderate, high, very high, and patients with very high cardiovascular risk according score system. They have very low level of their target level of LDL, less than 1.4 millimole per liter. Lipid screening, who need to be checked the lipid spectrum. By the way, lipid spectrum is, this is not, this analysis is not routine tests. That's why we have to find out, we have to repeat the indications for screening of the lipid spectrum. These are all patients, people older than 40, male patients older than 40 and female patients older than 50 years, or patients with female patients with menopause. Next indications, all patients with cardiovascular diseases or very high risk of cardiovascular diseases, all patients with familial hypercholesterolemia, independently from the age, patients with genetic predisposition to cardiovascular diseases, and in high risk of cardiovascular diseases, special groups of populations, patients with chronic autoimmune diseases, women with gestational diabetes or gestational hypertension, men with erectile dysfunction, antiretroviral infections, patients with chronic kidney disease and peripheral artery disease, and including asymptomatic patients but with a thickening of the intima media thickness complex. What should be the lipid levels? These are normal levels, parameters of lipid spectrum for general population, not for specific groups of patients. And we should know that there are some factors which can influence to lipid levels of the serum lipids. For instance, in healthy lifestyle, daily physical activity can increase the positive HDL cholesterol. On the other hand, hypertriglyceridemia, smoking and obesity can decrease HDL cholesterol. LDL cholesterol is usually increased in patients who keep high fat diet, especially saturated fats, patients with nephrotic syndrome, thyroid gland hypothyroidism, Cushing disease, diabetes, cholestasis, family predisposition, and patients who use alcohol or use high who receive high calorie diet, diabetes, obesity, nephrotic syndrome, family predisposition, Cushing's disease, they have usually high triglycerides. Is it possible to influence serum blood lipids by diet or lifestyle changes before starting the pharmacotherapy? Here we would like to apply to clinical guidelines from European Society of Cardiology, and in order to decrease total cholesterol and serum LDL cholesterol, it is highly recommended to avoid of trans fats, restriction of saturated fats, increase food fibers, use of functional foods rich of phytosterols, use of nutraceutical red yeast rices, and reduction of increased body weight. But here I would like to highlight your attention of trans fats. What is it, trans fats? By the way, trans fats, about trans fats, more than 1 century ago, at last century, at the beginning of last century, Wilhelm Norman, he got official patent about hydrogenation of liquid oils, but there are classification of trans fats. Natural, they can be natural or artificial. Natural, they usually are produced in the intestine of animals, mammal animals, or we can find out natural trans fats in milk, dairy, or meat products. They usually low percent, approximately 5%. But as for artificial trans fat or trans fatty acids, they are created in industrial process due to using hydrogen. Hydrogen passes into the liquid vegetable oils to make them more solid. And the main food current time, it's the main 21st century, the main food source of trans fats is in processed food. They are partially hydrogenated oils. And current time, unfortunately, these trans fats, they become very popular. And why companies use trans fats? Because there are different several beneficials, economical beneficials. They are very cheap, they have very long shelf life, they give the products a specific pleasant taste and appetizing shape. It is very easy to use trans fats because they are semi-solid in room temperature, and making them easy to use in baking. They can withstand repeated heating. They are used in commercial fryers, for instance, and they can be used for several weeks and months. But how do trans fats affect health, human health? Results of clinical investigations, they have revealed that consumption of trans fats increase the risk of cardiovascular diseases and stroke, and risk of onset of diabetes, type 2 diabetes. For instance, the consumption of every day only 5 grams of trans fats per day was associated with 23% increasing of risk of cardiovascular diseases. And results of investigations, they have revealed that trans fats increase concentration of triglycerides, of LPA, lipoprotein A, are increasing endothelial inflammation, endothelial dysfunction, and moreover, the consumption of trans fats in clinical studies was associated with increasing risk of arrhythmias. And here at the bottom right part of this slide, you can see comparison of influence of trans fats and saturated fats on the serum lipids, and increasing of using of the trans fats along with saturated fats, they can increase LDL cholesterol. But unlike saturated natural fats, the using of trans fats significantly decrease HDL cholesterol. It is harmful for human body. And results of clinical investigations, they led to decisions from official organizations. And here you can see the very authoritative organization, FDA, Food Drug Administration of the United States of America. And in 2015, this FDA, it released final recommendation that these trans fats, they are not recognized as a safe. And moreover, at the 2018, it published statements that manufacturers cannot add trans fats to food. And that's why we should take into account these official recommendations. But what products contain trans fats? Almost all fast food, fries, chicken wings from fast food restaurants, biscuit, cakes, waffles, pizza, etc. That's why these in patients with high risk or very high risk of cardiovascular complications, diseases, we recommend, we use specific recommendations to increase, to decrease LDL cholesterol. We take into account using of trans fats. We recommend to avoid of using trans fats and restrict consumption of saturated fatty acids. And in order to decrease LDL cholesterol, also the consumption of oil-rich or in unsaturated fats, they are beneficial for serum LDL cholesterol. How about influence on serum triglycerides? How can we improve plasma triglycerides in patients? We recommend weight loss, regular physical activity, and you should inform your patients that alcohol consumption, consumption of fructose and high carbohydrate diet can increase triglyceride levels. And here we apply to official documents. This table was uploaded, downloaded from European Society guidelines, clinical guidelines. And here you can see that power effect is maximal for reduction of alcohol consumption and increase in daily physical activity, reduction of consumption of carbohydrate, consumption of polyunsaturated fatty acids, and consumption of reduction of monodisaccharides. These clinical guidelines, they have, I want you to pay your attention to level of evidence. These guideline recommendations, they have obtained high level of evidence from clinical large randomized clinical studies and meta-analysis of randomized controlled studies. How about other parameters of the lipid spectrum? Is it possible to rise positive beneficial HDL cholesterol? According to the same clinical guidelines, is increase daily physical activity, avoid of trans fats, reduce or increase body weight, and reducing consumption of the carbohydrates and replacing them with unsaturated fats. They have maximal power of effect, and let's pay attention on the level of evidence. They have highest level of evidence, so it means that we can trust these recommendations. How about non-food recommendations? We can influence of lifestyle on cholesterol and LDL cholesterol by smoking cessation, and smoking cessation has a distinct positive effect on the overall cardiovascular risk and especially on the serum HDL cholesterol. How about alcohol consumption? Here I have used very large systematic analysis which were published in the very authoritative journal Lancet in 2018, and according to this large randomized large meta-analysis of randomized controlled trials, we can see that consumption of alcohol is closely related, is associated with increasing of all-cause mortality, all strokes, coronary diseases, excluding myocardial infarction, with the onset of heart failure and with deaths from other types of cardiovascular diseases. As for myocardial infarction, they have revealed decreasing incidence of prevalence of myocardial infarction with the consumption of alcohol, but let's focus our attention at the heart failure. The alcohol consumption, usual alcohol consumption, is directly associated with increasing onset of heart failure, taking in account that the main outcome of long-term outcome of myocardial infarction, this is heart failure. Finally, it is not reasonable to recommend alcohol for patients with prior myocardial infarction. And also, next information about alcohol, the other statistical analysis, they estimated future years of life lost by extent of reported baseline alcohol consumption, and they have revealed that alcohol consumption is associated, related with years of life lost in male and female patients. How about other recommendation about body weight and physical activity? So according to clinical studies, it is recommended to include diet and also exercise to lifestyle guidelines. And they have revealed that improving of physical fitness and quality of life and prevention of muscle and bone loss, especially in old people. As for patients with normal weight and overweight, the distinct analysis reveals that the physical moderate, so the physical activity is beneficial for all types of patients. For patients with normal weight, physical activity was beneficial because these patients, they got reducing of serum lipids, and in case of overweight, also physical activity improved lipid spectrum. That's why this is we can conclude that physical activity, in daily physical activity, this recommendation is universal for all patients with normal weight and also with overweight. So let's make conclusion. Alimentary fats are cleaved by enzymes and absorbed into the small intestine and transported to the bloodstream by the lymphatic system. Lipids are transported as a hydrophilic apolipoproteins. Lipoproteins control fat metabolism, and they are responsible for different functions. Dyslipidemia, they are typically characterized by increasing of serum cholesterol, LDL cholesterol, triglycerides, and dyslipidemia. These disorders, they are related with increased risk of cardiovascular diseases or with onset of cardiovascular diseases. Next conclusion: the causes of lipid disorders, they are the consequence of unhealthy lifestyle, and congenital causes are less common. For instance, familial hypercholesterolemia, which is associated with extremely high levels of total cholesterol, triglycerides, etc. And next conclusion: dyslipidemia can be detected by routine screening of serum lipids and screening of cardiovascular risk factors. The lipid spectrum of blood usually includes total cholesterol, LDL cholesterol, triglycerides, and HDL cholesterol. What are the criteria for dyslipidemia? Dyslipidemia can be considered if your LDL cholesterol exceeds 3.3 millimole per liter, and or HDL cholesterol less than 103 for male and less than 1.29 millimole per liter in female. If your triglycerides more than 1.7 millimole per liter, and at this presence of any of above mentioned criteria in one patient can be reason for putting diagnosed dyslipidemia. Next conclusion: 10-year absolute risk of development of cardiovascular events related to atherosclerosis can be calculated via the score system. The cutoff level for this conclusion, this is 5%. If your patient's score system revealed risk at least 5% and more, your patient is considered as high elevated risk of cardiovascular events. And the next conclusion: treatment of increased blood lipids usually includes lifestyle changes and hyperlipidemic drugs. About hyperlipidemic drugs, this is a question of the next lecture. This is a list of references I have used for preparing for this presentation. We have finished the lecture. Thank you very much for attention.